welcome everybody that has joined. This is the first Over the Bloody Moon masterclass of 2025. So it's lovely to see some familiar faces, and welcome to those that are new and also joining on catch up. So I'm delighted to welcome back Dr. Claire Phipps, who is a GP and also a menopause specialist. Claire has an honorary position of sitting on the Medical Advisory Committee on the British Menopause Society, and that is not an easy thing to be asked. So I think it sort of sums up, Claire, your credentials in this space. So today's topic is on intimate health. If anybody has got any questions, you can send those to me privately as a private DM, or this is an open, safe space. So if you want to share, you can. We are recording this session, so we won't mention any names and things when we're kind of, reading out any questions. But just to set the boundaries, it's not a private consult with Dr. Phipps. So if you do have a question, then make sure, please, it benefits the group. So Claire, I'm just going to let you just add a little bit more about you and your passions and maybe how you kind of got into menopause.
Yeah, thank you, Leslie. Thank you for having me. So as you said, by trade I'm a GP, but I became very, very interested in post-reproductive health in the latter part of my training, partly because I was, as a female GP, seeing lots of women and women's health issues coming through the door, and it seemed, and it probably still seems a little bit like this, that we are not managing women's health care and certainly intimate health care as well as we could. So I trained in menopause and became a menopause specialist. And really what I'm most keen on is thinking about menopause very, very holistically and enabling women to make choices about how they manage their menopause from a really well-informed position. So yes, we know HRT is one aspect, but there's lots and lots of different ways we can manage our menopause. And one of the key areas of interest for me is managing genitourinary syndrome of the menopause. So the genital symptoms essentially, and the pelvic symptoms that can come on in the menopause that are really often not talked about enough, and in certain communities really not talked about at all. But yet treatments can be really effective and can be game changing for many women. And so that's really my passion. That's what I'm kind of most interested in driving forward, is ensuring that every woman has that conversation as well when they see someone.
It's so important in terms of getting the right information and also early information, because some of the issues around intimate health can actually be prevented, or at least sort of spotted earlier. So let's just kind of start by, what do we mean by intimate health?
Yeah, so I suppose, intimate health is really this umbrella term. Specifically, if we think about it in the menopause, we're thinking about how your vaginal and vulval health might be affected, but we're also thinking about sexual function, we're thinking about your urinary health, we're thinking about the emotional and psychological aspects of the menopause that can influence your intimate health. And we're thinking about how we can support all of that during the menopause when we know those changes that are occurring due to hormonal fluctuations and the decline, particularly in estrogen. We know that these changes can really significantly impact intimate health. So again, we're talking about, dryness of the vagina and the vulva. We're talking about pain during intercourse. We're talking about having to pee more frequently or recurrent urine infections. All of those things really are our intimate health and how we're managing and how we're looking after our intimate health.
That's really helpful. Thank you. And so let's kind of just touch a little bit more on the hormonal changes that are happening. Do they start in perimenopause, or is it really post-menopause? And what's going on to cause some of these issues and changes?
Yeah, so as many of you will know, what we know about the sort of the beginnings of the perimenopause, if you like, and then onwards from that phase, we know that our hormone levels, our reproductive hormone levels, change quite quickly. So early in the stages of perimenopause, we may not notice very much change in our intimate health. And by that, I mean, vaginal dryness, just for an example. And that might be because for some women, our hormones in the perimenopause actually elevate a little bit. They go up slightly before they start to gradually decline. And it's as they gradually decline that we see more of these symptoms occurring. So what we call them is genitourinary syndrome of the menopause, collective mouthful for all of these symptoms that can occur. So it was actually the decline in these hormones, probably in the mid to later stages of the perimenopause. And remember, that term just refers to the fact that you're still probably having periods. They may be very infrequent, but you haven't gone 12 months without a period. So that transition can start to change the health of the vulva and the vagina. And that's a really important change to recognise and track, because that on its own can cause lots of different issues such as sexual dysfunction, pain, urine infections, like we said. And so it's the hormone changes that are occurring that are essentially leading to these symptoms. And the reason is that we have really high concentrations of estrogen receptors in our pelvis, in our pelvic floor, in our vaginas, in our vulvas. And actually, estrogen is really, really sensitive in those areas. And as those levels decline, as we lose that, those tissues, that health of those tissues suffer. And that's why it's really important to recognise early.
And I do think we don't pay enough attention to that area. We kind of, just forget about it. I mean, there's quite a few different things that we could talk about under the umbrella of intimate health. One of the things I think that's really helpful is sit in front of a mirror and look at your vulva area, and just see whether there is, it might be actually the first time that you've probably had a look, so you might not know how it changes, but at least kind of looking at it, and over time you can start to understand where the tissue and kind of if there's some changes. But I'd like to talk about kind of what is normal, and what isn't. And there's kind of different things that are popping into my head, and I can never say the right term for it, but the lichen, the one that's white. And so if you want to kind of, and there's of course kind of bladder leaks and dryness, etc. So maybe if we kind of take a few of the what's not normal, and then kind of go through what the symptoms are, that would be really helpful.
Yeah, and I think what you said initially is really key, is knowing what is normal for you is absolutely vital in order to recognize what's not normal, because that will differ in different women. And so, encouraging everyone really to really observe their intimate health, really look at the tissues and really observe what is normal for them. Obviously, many of us don't do that. So what do you do when you think there's a problem? I guess the main symptoms we are looking for are, yes, dryness. So that could be just pain sitting down, pain putting underwear on. That could be a little bit of spotting after intercourse or pain during intercourse. It could be urine leakage or needing to rush to the toilet. It could be the feeling that your labia, your vulva are dry and itchy. It could also just feel like you're weaker in that area, you're less able to hold on to your urine, so you might be incontinent. Those are typical symptoms of estrogen deficiency. And I guess those are the ones, I mean, any of these are ones I would say you need to visit your GP about, because we need to obviously examine you and make sure there isn't anything else going on. And you alluded to that there, Leslie, earlier with the lichen sclerosis. This is an autoimmune condition, and autoimmune conditions really are conditions where the body doesn't recognize itself as itself. So it thinks of it as a foreign body and starts to attack itself. And with lichen sclerosis, generally what this tends to be is whitish patches around the vulva and the labia, which are incredibly itchy and tend to be itchier at night. And many women self-treat multiple times with thrush pessaries or cream because they feel like they've got thrush. And so Actually, that's fine. If you've treated yourself once or twice with over-the-counter treatments and it's not effective, see your GP so they can examine you and make sure we're not missing something else. And then any skin changes you notice, anything that's, a different color than normal, or if you've got any lumps and bumps, obviously go and get those checked out because you do need an examination for us to make a diagnosis. What I would say is obviously keep up to date with your smear tests. Smears are really vital, particularly if you've experienced any spotting. Um, and really thinking about just overall health. So has anything else changed in your health that might affect your intimate health? So, are there any other health conditions, any other medications that you might have been taking, and then you've suddenly noticed a change in your intimate health, in your vaginal discharge, for example, or in the kind of the color of the skin. Some medications can do that. So essentially, I think don't be afraid by going to your health care practitioner to have an examination because often it can be really reassuring, but it's also really vital that we're not just saying everything is down to menopause and an estrogen deficiency and not something else.
Thank you so much for explaining that. And let's talk a little bit about UTIs. Is there a particular kind of time in the menopause transition that they might increase, and what triggers it?
Yeah, unfortunately not. And again, this will vary for different individuals. What we know is that estrogen is a natural anti-inflammatory, and we know that it's really good at stopping bugs track up our urine tube, our urethra. And as those levels decline and as estrogen levels decline, not only do the tissues on the outside and the vagina get a bit drier, but the urine tube also gets a bit drier. That enables bugs to track up a lot more easily and to be transferred during sexual intercourse or after passing urine a lot more easily. And these can take hold. So it will, some women never have one, and some women have multiple UTIs during the perimenopause and beyond. Um, we know that treatments such as vaginal estrogen can really help to prevent that. And what we're looking for is obviously to improve your quality of life by not having a UTI. But really importantly, as we get older, we're more at risk of infection and we're more at risk of something called urosepsis, which is when we've got really bad urine infection that can track up to our kidneys and make us very, very poorly. And this is something we commonly see in very, very elderly women who perhaps haven't had vaginal estrogen. And that can be really quite dangerous. And I'm not here to scare anybody. It's just a reality. It's what happens. And so what we really need to do is notice that we're having a symptom, recognize it, track it, and then see your GP, practice nurse even. It might be that you have a chat about this at your smear test or your well woman check, but mention it because UTIs can be awful. I know whenever I've had a UTI, it's you're just sort of crawling around, aren't you? It's so incredibly painful. So obviously there's going to be a role for antibiotics here, but also there's going to be a role for vaginal estrogens too.
Mm. Let's talk a little bit about that as kind of a treatment. There's a little bit of misinformation in terms of if people can't be on HRT or don't want to be on HRT, then they can't take vaginal estrogen. Can you sort of share a little bit about the dosing and sort of what is safe and maybe what isn't?
Yeah, so I think the bottom line is that vaginal estrogen is incredibly safe, really safe. Some of the concern arises around women who've had a history of hormone receptor positive breast cancer, and can they or can't they use vaginal estrogen after they've had that diagnosis, or if they have or are still on some sort of hormonal treatment for that. I think what we've got to realise is that over and above everything, we're looking at quality of life and we're looking at making sure that we are treating you as confidently as possible. Um, and one of those things is of course vaginal estrogen. Now, there are some individuals and some women who've had a history of estrogen receptor positive breast cancers, and the jury is still out on whether or not vaginal estrogen should be used. However, and this is a big however, we've got to consider lots and lots of different factors when we are prescribing vaginal estrogen, such as quality of life, such as not having recurrent UTIs and urosepsis, like I mentioned, such as the ability to sexually function, and if that is a problem within a relationship, how that relationship might suffer, the inability for some of these women not to be able to exercise due to pain, leading to other issues such as weight gain and psychological problems. So I know that's me digressing, but I think vaginal estrogen can be really, really vital. And there's very few women who can't use it, very few women indeed. And what I, as a menopause specialist, and others would do is really have a discussion and individualize that discussion with every woman that we saw, to take into consideration their medical history and to make sure that we were doing the best possible for you. But having that shared discussion about what we know and what we don't know. And I think, Leslie, you and I were having this conversation before. There's an awful lot we don't know. But what we do know is that vaginal estrogen is really safe.
Mm. Can you just explain what it is, like the different formats for those that might not be familiar, and the different symptoms or how it can be helpful?
Yeah, so vaginal estrogen is not HRT, but it can be used aside HRT or on its own. Um, and what vaginal estrogen is a cream, a gel, a pessary, which looks like a little waxy bullet or a little tablet. And these are inserted into the vagina, depending on how often you would need to use it. Generally, we say use it sort of every night for 2 or 3 weeks when you first start, and then use it 2 to 3 times a week as a maintenance. But really, really importantly, if you're using one internally, you can also use a cream externally, a vaginal estrogen cream externally, if you've got labial dryness or vulval dryness, or just dryness around the clitoris or urethra. So you can use two different vaginal estrogen products together. Many of us will note that if you are needing to use one internally and one externally, we might just give you the cream because it just makes more sense. It's easier to use one product. But for some women, it's trial and error. We need to try, a few before we get you symptom controlled. Um, and that might be using two different products. But essentially, it's a treatment that's inserted into the vagina, and it can be used forever if you need to. There is also, Leslie, I don't have a picture. It's called an E-string. I don't know if you've seen those. They are little circular, flexible plastic rings that are inserted into the vagina and stay inside for 90 days. And they release a really slow form of estrogen into the vagina, so you don't need to change or add or insert a pessary 2 or 3 times a week. So they can be quite useful for people who have sort of dexterity problems or arthritis. For example, your GP or practice nurse can fit those, and sometimes women insert and take them out themselves.
And what's, I know you've explained, for example, in relation to UTIs, how
Mm.
vaginal estrogen helps, but what other symptoms might it prevent or help subside?
Yeah, so really what we're looking to do is we're looking to re-estrogenize the vagina so that it's comfortable for you. And again, that could be, I have women who can't ride a bike because it's so sore. So making you know day-to-day activities comfortable, exercising, for example, um, intercourse being more comfortable and more enjoyable as well. And we mentioned a bit about the estrogen receptors in the pelvic floor. So, our pelvic floor is basically held up by a nice big muscle. And as the estrogen declines, that can come slightly weaker. And that's what can often lead to those symptoms of urgency to pee and incontinence. And so, if we can use vaginal estrogen, we often find that supports those symptoms, and those symptoms can get better as well. So there's a whole host of of benefits really that can it can provide.
Fantastic. I just want to touch on a couple of other common aspects. So you've mentioned already vaginal dryness. So what are kind of, other than vaginal estrogen, what other things should people be doing and also avoiding?
Yeah, so as we said before, we're not great at looking after our intimate health. So I think one of the key things is, like we moisturize the rest of our body, we should be moisturizing our vulva and our labia. Um, and I wouldn't necessarily use the same moisturizer you use elsewhere. Some women use coconut oil, for example. But other ones, such as Yes moisturizer or Sutil lubricant, can be really helpful to moisturize as well. That I think we should get into the habit of doing more. Moving away from washing with any harsh soaps or shower gels, or even those that are marketed as feminine hygiene products. We don't need to be using them. We should just be using water or emollient to wash with, really, because that really maintains the pH balance in the area really quite well. Um, and really, in terms of moisturizers and lubricants, lubricants can be really effective, obviously, for intercourse. But they can be really effective, if you're having difficulty, or if you've had a painful smear test, for example. A few days before your smear, if you start using them, we know that actually the lubricants don't interfere with the smear taking anymore. And so using it before a smear test, if they can be just uncomfortable, can be really helpful. But the key ones are moisturize and lubricant, and avoid feminine hygiene products.
And also fragranced, heavily fragranced. And I was also reading, for example, if you stand in a shower and you're using quite a harsh shampoo, that of course is coming down your body. So maybe washing your hair, leaning over the bath and things if you're kind of sensitive in that area.
Yeah, exactly. I mean, I think, you know, we want to make we don't want to complicate things, do we? We don't want to make things really hard for people. But if you're someone that is more prone to thrush, for example, or who's more prone to having very, very sensitive vaginal vulval health, then yeah, avoiding anything that can get in that area, such as sitting in a bath with bath salts or a bath bomb, absolutely a no-no. And washing your hair over the shower rather than in it. But of course, with the best will in the world, that's not always possible. So it's just being mindful of it, really.
What's the BMS's viewpoint, or your viewpoint, if you don't know the BMS viewpoint, in terms of things like red light therapy, where which can be used by some people if they are finding that they've got, very painful dryness and sort of thin tissue, etc. Is there any evidence at the moment to show that that works?
No, I'm not aware. I'm not familiar with evidence for this. And I think if you've got really sore, if the area is really sore and really painful, I would encourage you to see your GP, because, first of all, we don't need to examine every person that comes in with those symptoms, but it's really helpful to be able to examine you briefly. That might not be inserting a speculum, that might just be having a look. And the reason for that is, obviously, we want to make sure that we're dealing with menopause symptoms and not something else. But if it has got to that point, then the key thing is if you're a candidate for vaginal estrogen and moisturizers, which, as we said before, most women are, then that is going to be the best, most evidence-based treatment for you.
Brilliant, fantastic. Let's move on and talk about bladder leaks, which become increasingly common, and another symptom that we can often ignore. Um, when should someone start to go and see a doctor? And what is kind of the pathway, I suppose, as well?
I think if it's bothering you, then see a doctor, no matter how long it's been bothering you for. Have it checked out. Um, we know that some of us don't go and visit a doctor until it's really bothering us. Um, But I would say the earlier you go and get it checked out, the better, because there are lots of simple things we can do, examination being one, but also pelvic floor exercise being another. Um, and again, pelvic floor exercises can be quite tricky to master yourself and to know that you're doing them correctly. So, your GP may be able to refer you to a women's pelvic floor physiotherapist so that they can guide you with treatment and make sure you're doing it correctly. Because with the best will in the world, they are hard to do. But I would definitely go earlier rather than later if you're having these symptoms, because of course it's going to be affecting your quality of life to a certain extent, isn't it? You're going to be worried about leaking, or wanting to know where the next loo is, or what we call latchkey incontinence, where you get to the front door and you leak because you desperately need to go. So see someone early and talk about options. You can have a look at pelvic floor exercises online. The NHS have got a great patient information leaflet on there, and that will guide you with kind of pelvic floor exercises. The other key thing to think about is obviously see your GP, but try to avoid any bladder irritants that might be making things worse. So typically those are your usual suspects. So smoking, caffeine, sweeteners can do that too. And so trying to avoid those can also be helpful, and may even make your symptoms a little bit better.
Brilliant. So let's kind of talk as well outside of medical treatment. I know we've already mentioned some things. Are there any other tips and good habits that we should be introducing?
Um, I think my biggest tip, other than the ones we've mentioned, is well, it is avoidance of the feminine hygiene products and the bath salts and the bath bombs, because they play havoc with the vaginal microbiome. So, like we've got a gut microbiome, which people may be familiar with, we've also got a vaginal microbiome, and we need to nurture that. And that's done in a similar way, really, to eating well to nurture our gut microbiome.
And
But that gets a bit.
does that include essential oils?
Yeah, so I mean, I wouldn't put essential oils in a bath and sit in a bath. No, I would try to avoid anything that could be irritant, and that can be. Um, as I said before, I think really what we should be washing with is only water or emollients, ideally. Those really are the biggest things that you could do to help yourself. Um, and occasionally, what we find is we're more prone to thrush or UTIs, like we've said, at this point in our lives, and we may be taking an antibiotic or a thrush treatment vaginally. We know antibiotics can knock out some of our good bacteria, and thrush treatments can too. So it's about making sure you're looking after yourself in other ways. So make sure your nutrition is as good as it can be without going kind of overboard, which can be, it's hard to do all these things, isn't it? It's time consuming to think about it all. But if any of that rings true with you, it's making sure that we're trying to eat as well as we can so that we can replace those good bacteria.
Let kind of, we're talking about, I suppose, averages and norms, but they're, kind of we all come into intimate health with our unique bodies and sort of unique history of how and why we are the way that we are. What other factors might make intimate health worse or different?
Yeah, so I guess really thinking about how, how we approach intimate health is really important. So we know that, we mentioned these before, that the physical changes that can happen, um, specifically around our bodies, but also how hormonal changes can affect our intimate health, and how that has a knock-on effect on our sexual function and our relationship, and even how we might orgasm and our urinary health. But we also know that that brings on emotional and psychological changes too. So mood fluctuations may affect intimacy as well. What we've got to really keep mindful of is those women who have had a previous trauma from previous, whether it's physical, emotional, sexual. we know during the menopause that sometimes these can resurface, and you know, we've just got to be mindful that sometimes at this point in our lives we're juggling a lot, but we are also very, very likely to drop one of those balls. And if we've had things that have affected our psychological, our mental health in the past, sometimes these can resurface. So it can have an impact on our sexual intimacy. It can also obviously have an emotional and psychological impact, and that the changing hormones can have a further psychological impact as well. So it's really just being aware and mindful and getting the support that you need. And if you feel that anything that I've mentioned is triggering for you, I'm really sorry. It's not meant to be, but there is support out there. And I think the key thing is accessing that support through a trusted source. So you can visit your GP and ask for referrals to sexual health clinics where they can go through psychology with you, and counselling and training with you to help. But there's also different avenues within that as well. So please don't be afraid to ask for that if you feel like you need it.
Brilliant. Thank you so much. So we're sort of a little bit over halfway. So I think I'm just going to take us off Spotlight and put us into gallery a minute. There we go. So we've kind of covered quite a lot already. From the audience, anyone got any questions? You can or don't have to put yourself on camera, but has anyone got any additional questions or areas that they want to explore around this before we move on to talk a little bit more about HRT? Just there's in the chat. So we have, can you give an example of a suitable emollient to wash with?
Yeah, there are lots of different types. Lots of them just can be bought over the counter. I commonly recommend Cetraben, which comes in a big tub of emollient. You've also got things like Hydromol, which is quite greasy, but can also be used as a moisturizer. Yes, do a really lovely moisturizer that you can also wash and moisturize with. Um, those are the main three that I tend to recommend. And there are other ones that are on prescription only, but you don't necessarily need to go down that route. So those are the main ones I would recommend.
Brilliant. So we've also got a question on testosterone and sort of the role in intimate health. So it'd be great to hear a bit more about that.
Yeah, and testosterone is having a bit of a moment, isn't it? I think testosterone can be really helpful for women's sexual health and intimate health. We have evidence that it can be, and it can boost desire, but we know that in women, desire is more than just about testosterone. And our levels do reduce as we progress through the perimenopause and beyond, but they're not a dramatic decline. Um, and we tend to find testosterone helpful when you've been on a good dose of HRT, and again, good dose will vary between different individuals, but when you've been on HRT and you still find that your desire or your libido is affected, that's when we would think about adding in testosterone. And for some, it can be really helpful, for others, less so. But it is a bit of trial and error. And we normally would say give it 4 or 5 months before we really know what it's doing. It's a bit of a slow burn. Before we know what it's doing, before we review blood tests, and then see if it's been a benefit for you. So it's really important to track, again, once you start using testosterone, to track any changes, positive or negative, so that we can assess. But testosterone can be used alongside HRT for women who are having low libido.
And I think it's we have to be careful as well, not just blaming hormones for low libido. There can of course be lots of different things going on. You've mentioned
Yes.
when you're really busy and you're tired, you just might not, feel like it. That's normal. As men and women as they go through midlife are going to kind of have changes. So I think also if I think where it becomes tricky is if you've got one person in a partnership who has got a, wants, has a different level of libido, and wants different kind of things. But it's also an opportunity to acknowledge, accept, and to reframe what that kind of intimacy might be. So if you are in a relationship with someone, being able to kind of talk about what's going on for you, and even any of the things that you've mentioned, be it incontinence, be it kind of irritation and itchiness and things, just being honest with your partner will help them understand why, and what they can do to support. Brilliant. Okay, so we're going to, oh, we've got here as well. Do swimming pools or sea swimming have an impact on like pH and?
Really good question. I think that potentially, yes, they do. So chlorinated water can have an impact on our vaginal health. Some women find that it can be a real irritant. Again, not everyone. And salty water, probably less so because it's saline and it's lovely and natural. But again, if you are someone that's already having symptoms of vaginal dryness and you'll see swimming a lot, you need to ask yourself if that's making those symptoms worse, because it might do in some women. So the sort of my kind of loose answer is yes, potentially it will have an effect, but not for everybody.
Amazing. Well, listen, thank you so much. It's always incredibly informative. We pack so much in.